Good morning, everyone. The today's topic for CCR from Department of Neurology is From Shadows to Clarity, the Art of Localizing the Elusive Epileptogenic Zone. On behalf of Department of Neurology, आप सभी को मंगलमय दीपोत्सव की हार्दिक शुभकामनाएं। The Neurology Department in MGH was established in 2015. We are 3 faculty members: Professor Mch Agrawal, Dr. Balveen Singh, and myself. DM courses were started in 2016 with 1 seat per year, which were increased to 5 seats per year in 2022. The total number of students so far 21, and we have proposed for epilepsy fellowship program as well. These are our neurophysiology and electrophysiology labs, where we are doing all investigations like EEG, nerve conduction studies, EMGs, evoked potentials. We are providing comprehensive epilepsy care. We are having a state-of-the-art epilepsy monitoring unit, and we are also performing the electrocorticography, which is most required in epilepsy surgery. We have 3 video EEG machines for continuous monitoring. 2 of them are portable, and we can do the sleep studies, the polysomnography. Now this graph shows that we acquired first video EEG machine 2 years back, but the video EEG studies have increased significantly over past 15 months since the epilepsy surgery is being done here. In fact, it came to me as a pleasant surprise when I joined the department and I learned that epilepsy surgery is being done already in this institution. And we have achieved a very important milestone of 50 plus epilepsy surgeries so far. And in fact, now we have 54. And the 54th case was operated in this month only. Our dedicated team for epilepsy surgery includes Dr. B.S. Sharma sir, Dr. Balveen Singh, and Dr. Ajay Goenka. And with the help of other departments, it's a teamwork, and we are able to achieve a very good success rate. We are also providing comprehensive stroke care, and these are the data for various neurointerventional procedures performed so far. We are also running subspecialty clinics of neurology, dementia and neuropsychology clinic, neuromuscular clinic, headache and pain clinic, movement disorders clinic, Botox for movement disorders and spasticity, and various other procedures like nerve biopsy, muscle biopsy. We are also providing comprehensive neurorehabilitation services with the help of PMR department. Coming to the research activities, we are having 5 ongoing DM theses, and the number of publications which are indexed on PubMed 31, on Google Scholar 21, on Scopus 20. We are proudly sharing that we have got a grant of $10,000 for our Epi Act program, in which Dr. Balveen Singh is the principal investigator. He will tell you some other details about it. Our faculty is participating in various conferences. Professor Mch Agrawal participating in conferences and workshops. Dr. Balveen Singh, very actively participating in various national and international conferences, workshops, and meetings. This was our recent media coverage of depicting the work being done in the department. Our senior residents are regularly participating in various conferences and workshops and getting awarded. Again, our senior residents. The department is organizing guest lectures from time to time, inviting various faculties from different fields. I couldn't anticipate during my felicitation in 2022 that this picture is going to be the future picture in 2024. Thank you for giving me an opportunity to serve here. Now I invite Dr. Pavni to begin our case.
I am Dr. Pavni Agrawal from the Department of Neurology. Today, our case is that of a 30-year-old right-handed gentleman who was born of a non-consanguineous marriage and has had epilepsy since the age of 5 years, a long-standing 25-year history. His seizure semiology, which is the clinical description of what a seizure looks like, is very consistent with an epigastric rising aura. The aura is the initiator of the seizure. It tells us about the exact location from where the seizure begins. The patient's aura was then followed by eye blinking, behavioral arrest, which eventually evolved to involve the whole brain and manifested as tonic-clonic movements of all 4 limbs associated with frothing, tongue bite, and urinary incontinence. His episodes last for around 2 to 3 minutes. And over time, his seizure frequency has progressively worsened, and currently, despite being on appropriate medications with proper adherence, he continues to have 1 to 2 episodes of seizure per week, with occasional clusters of 3 to 4 events in a day, which means that the seizures come back to back within a short period of time. His birth history and antenatal history was normal with normal developmental milestones. Now I would like someone from the audience to classify seizures for me. Thank you for your answer. So the simplified ILAE seizure classification framework classifies seizures primarily based on the onset of the seizures. Hence, they can be focal onset, onset of unknown, and generalized onset. And since our patient had an aura which is very consistent with the focal onset, so our patient has focal epilepsy. We then took a detailed drug history of the patient. He was started on monotherapy of levetiracetam in 2000, but as the seizures were not controlled, these drugs kept on building up. And currently, he is on 5 anti-seizure medications, which are appropriately chosen, are in weight-appropriate doses, and the patient has very good compliance. So, both the electrical activity and the visible clinical symptoms are captured on the video EEG monitor, as it has a very good temporal correlation.
So long means how long? Like overnight, 24 hours, few hours?
Sir,
what does long mean? How long do you record?
Sir, at least 24 hours, but we can go up to, we have even gone up to span of 5 days to 7 days to capture the event if necessary. Yes, sir, continuously. So coming back to our patient, this is the background rhythm of our patient, which explains how the brain waves are in between the events. The blue lines depict the brain activity on the left side, and the red lines depict the brain activity on the right side. The electrodes in even number are depicted in red, and the electrodes in odd number are depicted in blue, which are placed on the left side. And the electrodes are placed on the brain in such a way that it covers the whole brain. The background activity for our patient was normal and well organized. Now coming to the interictal EEG record, which means that the record in between the events or the seizures. And interictal epileptiform discharges are abnormal discharges, which in our case, in our patient, was coming from the left anterior temporal region. So as I had earlier shown in the representative animated video, this is the video EEG of our patient, where we have captured the semiology of the seizure with the ongoing electrical activity as depicted on the EEG. The patient over here is lying in supine position with eyes closed. In the EEG, we see that the rhythm has changed in the left temporal region as shown by the yellow arrow. This rhythm is then contaminated with myogenic artifacts. Simultaneously in the ongoing video, patient has had eye opening and he looks very confused. We now see that the abnormal rhythm stays on the left temporal region as again shown by the yellow arrow. This continues for a pretty long time on the left temporal region. Now the patient has dystonic posturing of both the upper limbs. And we see that this abnormal rhythm has now generalized and has involved the whole brain. The dystonic posturing has continued. Our technicians are made aware of the event. They come inside the room and they are testing the patient, to which the patient is completely non-responsive. This dystonic posturing continues. This event continues for around 2 minutes, during which he was not responsive to testing. And then this was followed by post-nasal confusion. So now, this video EEG recording has further ascertained that the onset of events is focal, and we have lateralized and localized it to the left temporal region. Coming to the lab investigations of our patient, they were normal. Now talking about the electroclinical correlate. So clinically we know patient has had an epigastric rising aura, which is classical for a temporal lobe epilepsy, which is a focal epilepsy. And electrically, patient had interictal discharges with phase reversal at F7 left temporal region and the ictal onset again from the left temporal region. Hence, we are lateralizing and localizing the events to the left temporal region. Now coming to the anatomo-electrical correlate. The anatomo-electrical correlate is a combination of 3 pieces of information. So EEG wise and clinically, our patient had episodes coming from the left temporal region. But then, to further localize to the true epileptogenic zone, we need to find the symptomatic structural lesion, for which we require a brain MRI. Now then, why are we trying to precisely localize this epileptogenic zone? Because this is the area of the brain from where the seizures begun. And localizing it is the key to a successful surgical outcome. Our patient has drug-resistant epilepsy with a very high pill burden and an impaired quality of life. And also, through the EEG, we have localized and lateralized to the events to the left temporal region. Hence, the ultimate goal, which is safe and lasting seizure control, will be achieved by an extensive pre-surgical workup. Hence, it is very essential to correctly localize the epileptogenic zone. So, to further take the case forward, I would like to invite Dr. Vikash from the Department of Radiodiagnosis.
Thank you, Dr. Pavni. Good morning, respected teachers, seniors, and my fellow colleagues. Myself, Dr. Vikash Khileri from the Department of Radiology, and I will be taking the case forward. As requested by the Department of Neurology, an brain MRI was performed for a 30-year-old patient with a history of seizures using the harness protocol, that is harmonized neuroimaging of epilepsy structural sequences. This protocol employs very thin sections without any interslice gap as compared to the routine brain MRI, allowing for better differentiation between the grey and white matter and providing superior resolution. In contrast, a routine brain MRI typically includes T1, T2 and flare sequences with a slice thickness of 3 to 5 mm, which are relatively thicker and requires less scan time, approximately 12 to 15 minutes. The harness protocol, however, acquires some millimetric slices, resulting in the longer scan duration, but offering enhanced anatomic detail, which is particularly useful for evaluating epilepsy and subtle cortical abnormalities. These are the T1 and flare images with the voxel size of 1 into 1 into 1 mm. And this is the coronal T2 weighted image with the voxel size 0.4 into 0.4 into 2 mm. This is the MRI brain of our patient. This is the T1. This is T1 axial, T2 coronal and flare sequences which are unremarkable with no definite evidence of mesial temporal sclerosis or focal cortical dysplasia. Now I would like to call Dr. Pavni to take the case further. Thank you.
Thank you, Dr. Vikash. So in our patient, both the clinical semiology and the EEG are localizing and lateralizing the events to the left temporal region. However, the MRI brain does not show a corresponding structural lesion, which then creates a gap in our evaluation. So to address this mismatch, we requested for functional imaging in form of a PET scan, for which I would like to call Dr. Kaushiki from the Department of Nuclear Medicine to take the case forward.
Good morning, respected dignitaries, faculty members, and my dear colleagues. I am Dr. Kaushiki from the Department of Nuclear Medicine, and I'll be discussing the PET-CT findings of this case. Before I start, I would like to tell you that brain is an obligate user of glucose and hence shows increased FDG uptake. Normally, the main reason for this intense uptake is increased glucose metabolism and increased regional blood flow to that area. These two factors are directly proportional to the neuronal activity of that particular area. So the patient was referred to us by the Department of Neurology, and so far we knew that the patient was a 30-year-old male who presented with drug-refractory epilepsy, and electroclinical correlate was suggestive of onset from the left temporal region. MRI brain acquired in harness protocol was reported to be normal. So what is the basic concept of PET-CT in cases of epilepsy? PET is a metabolic or functional scan, whereas CT is an anatomical aid. Usually in cases of oncology, we acquire the brain PET for around 2 minutes, which is for one frame. But in cases of epilepsy, we acquire it for 10 minutes, that is 5 frames lasting for 2 minutes. We acquire the brain PET for epilepsy in interictal phase. The time interval between two seizures is called as interictal phase. During this phase, the epileptogenic focus remains silent, which may be due to neuronal loss, due to decreased density of neurons in that area, or diachisis. In a case of interictal PET, we are looking for silent neurons or inactive neurons, which would be depicted as the green area or the area of hypometabolism, and the normal area would be depicted as red area or area of hypermetabolism or active neurons. These are the representative axial and coronal images of the patient. The red area is showing hypermetabolism or active neurons, whereas the contralateral right-sided temporal region is showing hypometabolism, or the neurons in this area are silent. Same goes for the axial section, where the left-sided temporal region is showing hypermetabolism or active or normal neurons, whereas the right side is showing green or hypometabolism or silent neurons. So we came to the conclusion that the right temporal region was showing relative area of hypometabolism, which was likely to be our epileptogenic zone. Now I would like to call Dr. Kanika Suri to take the case further.
Thank you, Dr. Kaushiki. Good morning to the respected faculty and everyone present here. I am Dr. Kanika Suri from the Department of Neurology, and I shall be taking the case forward. To summarize the case up till now, patient is a 30-year-old male with drug-refractory focal epilepsy. The semiology reported was that of an epigastric aura followed by behavioral arrest and then progressed to bilateral tonic-clonic seizures, being concordant with the localization in the left temporal lobe. The EEG showed ictal onset from the left temporal region, making it concordant with the clinical semiology and localization in the left temporal lobe. However, the MRI did not reveal any structural abnormality and was therefore non-concordant with the clinical and electrophysiological data. The FDG PET showed hypometabolism in the right anterior temporal, thereby highlighting a discordance between the imaging findings and the clinical EEG localization. Thus, the overall lateralization and localization remained unclear. So, why localizing the epileptic focus matters? Around 60 to 70% of the focal epilepsies have an identifiable structural pathology on neuroimaging. And here's the key point: if we can accurately identify the epileptic focus, it can cure the seizures, not only just control them. That's why precise localization is absolutely critical for successful surgical treatment. So at this point, we had a problem. Everything clinically pointed towards the left temporal lobe, that is the semiology and the EEG, yet the neuroimaging was telling a completely different story. In focal epilepsy, surgery can be curative, but only if we pinpoint the true epileptogenic zone. So in this case, however, the discordance between the EEG, MRI and PET findings posed a challenge in precisely identifying the epileptic focus. So we needed to look beyond what the eye can see. That's why we turned to advanced post-processing tools, including hippocampal volumetry and PET asymmetry after anatomical symmetrization co-registered to MRI, which is PASCOM, to aid in accurately localizing the seizure onset zone. Firstly, we performed hippocampal volumetry to evaluate any subtle structural changes. So here we take a 3D T1 weighted MRI and the absolute hippocampal volume is measured and compared against age and sex matched normative data. If one side of the hippocampus volume is less than the other, we may have a clue that that is the affected site. This method allows detection of hippocampal atrophy that may not be evident on routine MRI scans. The analysis can be done manually or automatically using specialized software. So this is how a manual hippocampal volumetry is done. Here we have to manually trace the hippocampus in all planes, and the software then calculates the hippocampal volume, gives an accurate quantitative measurement for the comparison with normative data. This method is what we've been traditionally doing in a hospital. However, due to the long processing time and intraoperator variability, we performed an automated hippocampal volumetry. So now we performed an automated hippocampal volumetry. Here we feed the software with the data and it interprets the results after segmenting the hippocampus. MRI harness helps us to do the hippocampal volumetry. As shown in picture A, you see a 2D view of the hippocampus, and in picture B, we see a 3D reconstruction. During automated segmentation, the computer identifies all slices, boundaries and subfields and generates a spot graph and calculates the volume. The software then compares the volumes of the two hippocampi to age and sex matched normative data and generates a spot graph reflecting this comparison as such in this patient. So this is the spot graph of our patient. Blue represents the control or the normative data. Green shows that the left hippocampus volume is less, and purple depicts that the right hippocampal volume is less. The red spot shown in between shows our patient's hippocampal volume, which closely overlaps with the blue, indicating that both hippocampi are symmetrical within normal limits with no evidence of hippocampal sclerosis. So hippocampal volumetry in this case did not lead us to any specific lateralization. Next, we moved on to an automated technique called PASCOM, which stands for PET asymmetry after anatomical symmetrization co-registered to MRI. Before analyzing our patient's PASCOM results, I'll first give a brief overview of the PASCOM workflow. So in this, firstly, we co-register the FDG PET scan with the MRI to align the metabolic and structural images accurately. Next, we flip and symmetrize, allowing accurate comparison between the two hemispheres. Next, we perform voxel by voxel subtraction between the two hemispheres to highlight the metabolic differences. This difference is then visualized as a bright focus on the map, highlighting the likely epileptogenic focus. So we ran the PASCOM analysis of our patient. Here we can see that this is the MRI and PET scan of our patient, which we first co-register to align both the images accurately. Following this, we flip and symmetricize the images, and finally we visualize the metabolic differences. So here we can see areas of hypometabolism appearing as orange in the right temporal lobe, which is concordant with the findings of the PET scan. However, during the analysis, the numerical values of the PASCOM revealed that the PET CT used was in fact an ictal PET rather than an interictal one. So in some patients like ours, there are subtle focal seizures that often go unnoticed, and distinguishing between the ictal and interictal PET scans can be challenging, as the difference is often not visualized to naked eye. Before I further proceed, I would like to brief upon the key concept to understand the difference between an ictal and an interictal PET. In an interictal PET, which we usually do, is done between the seizures. The epileptogenic zone shows hypometabolism, that is reduced glucose uptake, because the region is functionally suppressed. In contrast, during an ictal PET performed during or soon after a seizure, the same focus shows hypermetabolism, reflecting increased glucose consumption due to active seizure activity. So now that we've learned that in ictal PET, the epileptogenic zone appears hypermetabolic. So therefore, the true epileptogenic zone was expected to be a hypermetabolic focus in our patient. So we reran the PASCOM using correctly identified ictal PET data. So with the proper values applied, the analysis revealed a clear hypermetabolic zone in the left temporal region, aligning with our clinical and EEG findings. So the final outcome of our post-processing tools was that we identified a hypermetabolic zone in left temporal region, correlating well with the semiology confirming localization of the seizure onset. In the light of this PASCOM intelligence tool, we requested the nuclear medicine team to comment upon the metabolic differences.
In light of the PASCOM findings, the previous PET-CT scan was reviewed, now as a study that was acquired in ictal phase. Now we are in ictal phase. The neurons are active at the epileptogenic focus. This time around, we are going to look for hypermetabolism or active neurons. For the sake of revision, red is active and green is inactive. So, we noted a relative area of hypermetabolism in the left temporal region, and on the contralateral right side, we saw an area of relative hypometabolism or silent focus. The same findings were seen in the axial images. These were the sagittal images that showed hypermetabolic red area in the left temporal region and relative hypometabolic area in the right temporal region. So the final findings of the PET-CT scan acquired in ictal phase were relative hypermetabolism in the left temporal cortex, which was likely to be our epileptogenic zone. Now I would like to call Dr. Kanika to take the discussion further.
Thank you, Dr. Kaushiki. So now the semiology, EEG, ictal PET and PASCOM analysis were all concording, correctly localizing and lateralizing the epileptogenic focus to the left temporal lobe. However, the final piece of the puzzle, MRI, was still missing, which was crucial to identify any structural lesion and complete the pre-surgical evaluation. Considering that the epileptogenic focus was suspected in the left temporal lobe, we requested high-resolution, thin-section MRI cuts of the temporal region to detect any subtle structural abnormalities. And to walk us through these detailed imaging findings, I would now like to invite Dr. Vikash from Department of Radiodiagnosis.
Thank you, Dr. Kanika. Since the EEG and other findings was pointing toward the pathology in the left temporal lobe, we re-evaluated the scan and found some subtle suspicious abnormality in the left temporal lobe anteromedially as evidenced by subtle gray-white matter junction irregularity. So we repeated the corner T2-weighted scan with further thin section of about 1.5 mm, smaller field of view, increase in the matrix and next number of excitation. These are the T1 and T2 weighted coronal images. Here we can see in the right temporal lobe there is a gray-white matter is well differentiated, but in the left temporal lobe there is a subtle loss of gray-white matter junction irregularity is seen. And in this T2 weighted coronal image we can see there is a subtle increase in the cortical thickness which is suspicious for the focal cortical dysplasia. Thank you. I would like to call Dr. Kanika to take the case forward.
So now we move on to unmasking of the seizure focus. Taken together, these findings from multiple modalities were all concording, consistently pinpointing the epileptogenic zone to the left temporal lobe. To validate that the suspicious zone we identified was truly the epileptogenic focus, we relied on two key pieces of evidence. First, histopathological confirmation from the resected tissue, and second, clinical validation in form of sustained seizure freedom after surgery. So we thoroughly counseled the patient explaining the potential risks, complications of the surgery, and went ahead with electrocorticography guided epilepsy surgery. To discuss the surgical procedure as well as intraoperative and postoperative findings, I would now like to invite Dr. Vartika from Department of Neurosurgery.
Thank you, Dr. Kanika. Good morning, everyone. I am Dr. Vartika from the Department of Neurosurgery. First, we will be overviewing the case, followed by discussing the surgical aspect of it. The patient is a 30-year-old right-handed male born in a non-consanguineous marriage. He has had seizures since the age of 5, the frequency of which was variable initially, and now it persists to 1 to 2 episodes per week. We took the patients on multiple anti-seizure medications such as levetiracetam, carbamazepine, phenytoin, phenobarbital and clobazam, but the patient was diagnosed with drug-resistant focal epilepsy via following investigations. The EEG findings were suggestive of left temporal region epilepsy. Further MRI, PET scan and PASCOM was done. The final correlation was done clinically via EEG and PET PASCOM, which was concordant and was suggestive of left temporal epileptogenic focus. The next step in this was the resective surgery for the potential seizure freedom. The surgery which we chose for this patient was the standard anterior temporal lobectomy, which is the resection of anterior temporal neocortex and mesial temporal structures such as amygdala, hippocampus, fusiform gyrus, parahippocampal gyrus and uncus. Talking about the extent of the resection, it is 3 to 4 centimeters from the anterior temporal pole in the dominant lobe and 5 to 6 centimeters in the non-dominant lobe. We recommend the sparing of the superior temporal gyrus regardless of the site of the surgery, and the extent of resection in temporal lobe lobectomy varies and is not standardized. Now coming to the surgery, the patient was placed in a supine position and draped in a sterile manner. We took a curvilinear question mark incision over the left temporal region, beginning 1 to 2 centimeters anterior to tragus and extending upwards and posteriorly. A single myocutaneous flap was raised, which was followed by a temporal craniotomy and raising the bone flap and opening the dura. As I mentioned earlier, the margins of resection are not standardized. Therefore, we took the help of ECOG intraoperatively to confirm and refine these margins. If we ask what is ECOG, ECOG is basically ECG leads which are not placed on the skin but they are placed on the brain directly to confirm the signals. As we can see in the preoperative ECOG, these spikes confirm that we are on the right track of the resection. Here is a brief video showing our surgery. The cortex was marked with bipolar from the tip of the temporal lobe. Now here is a picture illustrating the temporal lobe anatomy, showing the superior, middle and the inferior temporal gyrus, and we can also see the sylvian veins. Proceeding with the lateral neocortical resection until we reach the floor of the middle temporal fossa. The resection was done in a layer by layer fashion using bipolar cautery, micro scissors and suction to minimize the damage to the adjacent structures. Here we can see the middle temporal fossa floor, following which we proceeded with the subpial medial temporal cortex dissection to find the temporal horn, and then we located the uncus by following the tentorial edge anteromedially, and the uncus was removed, which also helps in exposing the tip of the temporal horn spontaneously. Here we can see the uncus, following which we placed cottonoid to prevent the contamination in the field. After this, medial structures were identified and resected. Hippocampus was identified between the collateral eminence and choroidal fissure, and body was identified to be lined with the choroid plexus. Here we can see that hippocampus was identified and removed. After this, we proceeded with the removal of the parohippocampal gyrus, which was dissected and peeled off from the collateral sulcus. Here the choroidal point is also identified. The care has to be taken to preserve the surrounding vital structures such as optic radiation and MCA branches. The final step is the resection of amygdala while emptying the contents of the anterior uncus. After resection, the bleeding is meticulously controlled using the bipolar and oxidized cellulose. The limit of the resection is determined by seeing oculomotor nerve and also the PCOM artery, as you can see in the following video. This step shows the controlling of the bleed, and after which the ECOG was placed again to see if the resection was done adequately or not. Here we can see the comparison between the post-op and preoperative ECOG. The absence of any spikes shows that the resection was done adequately, and no post-operative seizure spikes can be visualized. The patient was discharged on day 5 and the extubation was done post-operatively. The surgical procedure was uneventful. The resected part was then sent for histopathology for confirming the diagnosis, the findings of which would be discussed by Dr. Vijaya Dhaka from the Department of Pathology. Thank you.
Thank you, Dr. Vartika. Good morning, everyone. I am Dr. Vijaya Dhaka from Department of Pathology. I will be discussing the histopathological aspects of this case. So, we received a formalin fixed biopsy specimen measuring 6 into 4 into 1.5 centimeter. On microscopic examinations, sections studied show cortical tissue with both radial and tangential dyslamination. Here in image A, at low power, we can see neurons arranged in columns forming a characteristic string of pearl appearance. In image B, at high power, we get a magnified view of dysmorphic neurons and a few balloon cells. In image C, at low power, areas of reactive glioses are also seen. So, based on the microscopic findings, the diagnosis was made as focal cortical dysplasia type 2B. Now I would like to call Dr. Kanika to take the case forward.
Thank you, Dr. Vijaya. So, using a multimodal approach, the clinical semiology, EEG, MRI, ICTIL, PET and PASCOM, we consistently localize the epileptogenic zone to the left temporal lobe, a true triumph of precision. To confirm the epileptic focus, we relied on additional evidence, that is, one, ECOG findings during surgery revealed left temporal spikes, and histopathology of the resected tissue showed focal cortical dysplasia, with all findings being perfectly concordant. The ultimate validation...
Can I ask a question? Suppose the focused MRI had not shown an anatomical lesion, would you still have proceeded with the surgery?
Yes, sir, we would have. We would have, because except for MRI, all other findings were consistent, and the main cornerstone is clinical localization and the ictal localization, which is very well concordant with each other. Clinical semiology stated left temporal, and similarly the EEG, which is the cornerstone of localization. So the ultimate validation came from the patient's outcome. He remained completely seizure-free for the past 11 months. We also have a patient testimonial video sharing the patient's journey and experience before and after the treatment.
30 वर्ष है और मैं कई प्रकार के दौरे आ गए और मैं कई जगह से दवाई ले ली मैंने, फिर भी मेरे दौरे नहीं रुक रहे थे। इसके बाद मैं महात्मा गांधी में डॉक्टर बलवंत सिंह से मिला। उन्होंने मेरी जांचें करवाई। जांचों में मेरे को बताया गया कि आपका ऑपरेशन होगा। उन्होंने बताया कि आपका ऑपरेशन डॉक्टर वीएस शर्मा करेंगे। फिर उन्होंने मेरे को वीएस शर्मा से मिलवाया। उन्होंने मेरी सर्जरी करवाई। सर्जरी के बाद मैं आज बिल्कुल ठीक हूँ। आज किसी प्रकार का मेरे को थोड़ा नहीं आता है।
Now I would like to invite Dr. Balveen sir to enlighten us with the review of literature.
So is he on some anti-epileptic or zero medication?
He is on anti-epileptics. He is actually on the same anti-epileptics. We actually start tapering after a year.
A very good morning to all dignitaries, colleagues, students and my dear friends. So time and again we have proved, the literature has proved that epilepsy surgery when it comes to drug refractory focal epilepsy is always a standard thing. It has been time and again proven that as compared to the medical group, the surgical group, you have to give the patient the option to get cured from the disease if you have localized it. Whereas if you just keep on adding the drugs, the chances of seizure freedom after an addition of third drug goes by less than 5%, fourth drug less than 1%, fifth drug less than 0.5%. So we should always give them the option of surgery. In fact, long-term outcomes of epilepsy surgeries have also proven to be good. Initially, traditionally, there was a saying that if you take out the hippocampus, the volume might go down, the memory might go down, patient might have disabilities. But when studied in a long-term data, including the neuropsychology, the patient's awareness, the patient memory, in fact, improved post-surgery because the burden of anti-seizure medicine goes down and that continuous seizure burden goes down. This is something which was new that we are doing, morphometric MRI analysis. So we are not just doing the traditional MRIs and traditional PET scans. We are incorporating the artificial intelligence. We are incorporating the new softwares. Basically, we are trying to mix and match engineering with medical science. And I think that is the need of the hour. Functional neuroimaging has a role. Multimodal concordance always gets our stakes very high. And one question that was asked that had this MRI been negative, so there have been case reports initially from the Brazilian paper which says that there are patients with MRI negative PET positive epilepsy. So from there on it has been time and again proven that MRI negative is nothing but we are just not able to see the structural pathology. Now with the advent of 7 Tesla MRI, we might be able to precisely localize better. The take-home message is epilepsy surgery is a safe and effective process with up to 80% chances of complete seizure freedom if the localization is identified promptly and appropriately. It can not only control seizures, but it can cure epilepsy. Normal imaging doesn't rule out focal epilepsy, and a multimodal approach combining clinical evaluation, advanced imaging improves seizure focus localization. This case is going to be presented at IronCon National Conference as an e-poster by Dr. Pavni Agrawal, one of our senior residents. So we will not just end here. A few slides about looking ahead. What is the future of neurology at MGH that we hope for in the next, say, 6 months to 1 year time. So our epilepsy program continues to grow. We have a lot of patients, and the increasing patient volume means there is a 1 month of waiting list. So now installation of 4th long-term video EEG machine is underway, and we are expanding the capacity for 24/7 monitoring and pre-surgical evaluation. In fact, we are also trying to get a invasive EEG now. For the stroke care, now we are going to be Rajasthan's best equipped stroke lab, and in collaboration with Dr. Madan, I hope he is here. Dr. Madan Mohan Gupta has recently joined the Department of Neurointervention. It's going to be a great collaborative work, and we are going to take stroke forward with most advanced stroke care, including a 4D technology, Syngo Dyna CT. With the leadership of Dr. B.S. Sharma sir, we are soon to start with the functional neurosurgical program, in which we are going to do stereotactic procedures including deep brain stimulation and stereo EEG monitoring with RF ablations for complex epilepsy cases, as well as Parkinson's disease, dystonia and chronic pain patients.
You could add stereotactic biopsies in that also. That will help us.
So the minute we have functional neurosurgery in, the whole stereotaxy room will become open. With the collaboration with the Department of Physical Medicine Rehab, we are already underway to integrate the neurorehabilitation program, and we have already asked for robotic assisted therapy. This is not only just going to help the neurology department per se, but neurosurgery, orthopedics, plastic surgery, and robotic therapy is one of the most advanced therapies that we need to push forward to. Different robots, sir. So there we have around 7 to 8 robots. I recently visited Kokilaben Hospital at Bombay. They have the best facility when it comes to the rehab section. So they have 7 to 8 robots which are differed from for different parts of the body. Like for hand weakness, for distal weakness, there are different robotic instruments. For paraplegic patients who are not able to stand, they have different robots. No, sir. Different machines for each. So somewhere around 2 to 3 machines at the beginning we need, and then we can always go ahead with more.
Did you ask for the cost?
Yes, sir. The whole system somewhere costs around 4 to 5 CR, but the initial things that we want will come out somewhere to be around 2 CR. I've already had a word with the chairman sir, and maybe by next 2 to 3 months we're going to push for it, sir. Now with Dr. Suresh sir in the team, we are going to develop a neuro-otology subsection as well. In fact, we have a neuro-equilibrium team working with us, with Dr. Anita Bandari ma'am, and we are collaborating with her over a project as well. So soon we'll be, in fact we are trying to start observership as a neuro-otology subsection group. So vertigo is not basically BPPV and treating with Vertins. The neuro-otology people and the neuro-otology subsection very strongly says that there is no role of Vertin, because Vertin is a vestibular suppressant. We need to take out the cranulithiasis and not give and push the patients to Vertin. So with neuro-otology subsection we'll be doing that thoroughly. Sleep study, we are already doing sleep studies, but we are going to go one step ahead now, and we want to be the Rajasthan's first neurosomnology sleep studying unit, in which we have to collaborate with the Department of Respiratory Medicine as well. Last but not the least, I would like to thank management of MGUMST, B.S. Sharma sir, Department of Neurosurgery. Without guidance, without push, nothing would have been possible. Department of Radiodiagnosis, specifically Vineet Mishra sir, because I know he has a busy schedule and there are a lot of patients, and I just give him a call, one more thin section cut, and he never says no. Department of Nuclear Medicine, again, Tarun sir and I, we bang lot of heads in hypometabolic and hypermetabolic areas. Department of Neuropathology, Surabhi ma'am, who always tells us the real story, what is the biopsy like. Department of Neuroanesthesia, special thanks to them, because during intraoperative procedures, we don't allow them to give the heavy dose anesthetic agents that they usually give, because it suppresses the ECOG activity. Our neurotechnicians, Shamir, who is a dear friend who has discovered and made PASCOM, the CCR review committee, especially Jaiswal sir for all his contributions and input, and obviously the patient and the family. Today we celebrate World Stroke Day, and in collaboration with Dr. Madan, we are doing an awareness program as well today. So all interested individuals are invited for the same. Thank you.